Let me tell you a little bit about Dr. Gawande's background. He's really a remarkable individual. I have to have a list here. There's so many things. He's a staff member at the Brigham and Women's, as I told you before. He's associate professor of surgery at Harvard. He's also associate professor in the Department of Health Policy and Management at the Harvard School of Public Health and associate director for the Brigham and Women's Hospital Center for Surgery and Public Health. He received his undergraduate degree from Stanford, a master's in politics, philosophy, and economics as well from Oxford University, his MD from Harvard Medical School, and his MPH from the Harvard School of Public Health as well. He's served as a senior health policy advisor in the Clinton presidential campaign and in the Clinton White House. And since 1998, he's been a staff writer for the New Yorker magazine. He's director of the World Health Organization's Global Challenge for Safer Surgical Care as well. So many of you know Dr. Gawande from his very apparent literary talents as well. I was talking with him this morning about how he developed such a clear writing style, and he says it's just not natural talent, but from practice, and I don't believe that for a minute. But he's received the MacArthur Award for his research and writing. His book, Complications, was a finalist for the National Book Award in 2002, and is published in more than 100 countries. His most recent book is called Better, A Surgeon's Notes on Performance, and that's a New York Times bestseller and one of Amazon.com's 10 best books of 2007. So we're very honored to have Atul speaking to us today. Thanks for coming.
Thank you, Dr. Campbell, for that extremely kind introduction, but also, most of all, for the chance to come talk to you. And if I can walk away from the podium a little bit, it might be a little bit easier, as long as I don't cause noises. Maybe it will work, and maybe it won't work. I wanted to start this chance to talk to you a little bit just with a story, mainly because I think in stories. And so the story I want to tell is one that I think helps illustrate the extent of our capabilities in medicine, and also the interesting and I think fundamental problems that those capabilities reveal. This was a case report that appeared in the surgical literature a few years ago, and it was from a hospital in Austria. They had a 3-year-old girl who'd come in. The story had begun when she had been out on a walk with her parents. It was wintertime. They had gone on a walk around a lake, a pond, and they lost sight of their 3-year-old girl for just long enough to see her go into the icy fish pond and then under the surface. You can imagine how frantic the parents were. They dove in to find her, and they could not find her. It took 30 minutes before they finally could locate her on the bottom of that frozen fish pond, pull her to the surface, and get her to shore. They immediately called from their cell phone to the equivalent of 911, and the team there told them how to do cardiopulmonary resuscitation. So they started doing chest compressions and giving breaths, and about 8 minutes later, the rescue team arrived. What the rescue team found was a little 3-year-old girl who was blue, without a pulse. Her temperature was 66 degrees. She wasn't breathing, and her pupils were dilated, which many of you know means that her brain was no longer functioning. She was, in other words, gone. But as all of you also know, you're reluctant to let a 3-year-old girl go. And so they continued their chest compressions and resuscitation. A helicopter arrived, and they brought the girl to the hospital, and they bypassed the emergency room and went straight into an operating room where they got the girl onto cardiopulmonary bypass. By the time the machine, the heart-lung machine, was up and running, the lines were inserted into her femoral vessels and sewn into place, though, it had been a full hour and a half since she'd gone under that surface of that pond. At 2 hours, though, her temperature had warmed up 10 degrees, and her heart began to beat. It was the first organ for her to come back. At 6 hours, Her temperature was now up to 98.6 degrees. They wanted to switch her off of the cardiopulmonary bypass. These are not machines that are made to sustain you for long periods of time. And what they wanted to do was get her onto a ventilator. Her lungs, however, were too damaged by the pond water to allow for the air that they would put down through the endotracheal tube to pass oxygen into the bloodstream. And so they needed to continue on bypass. They therefore brought a different kind of machine in, one actually pioneered here, the ECMO machine, extracorporeal membrane oxygenation. And in order to get that hooked up, they sawed open the girl's chest. They sewed an inflow and outflow line into her heart and her aorta. And they got her switched over to the machine, which was portable and allowed them to transport her to the ICU. She stayed then on essentially heart-lung bypass overnight. And over 24 hours, her lungs actually recovered enough that they could take her off of the machine, put her on a mechanical ventilator, and then close her chest up. For 2 days, they continued to watch her, and gradually, all her organs came back. Her kidneys, her liver, which had been in shock. Everything except her brain. They got a CT scan, and it showed a great degree of swelling. It was pushing up against the outer limits of the child's skull. But there was no evidence of dead zones. There was no sign that she had stroked out, as we would say. And so they thought there was still a glimmer of hope. They therefore took her back to the ICU. They drilled a hole in her skull and placed a probe that would allow them to monitor the pressure in the cerebrospinal fluid. And then they could adjust their medications, their IV fluids, the various treatments they were providing in order to make sure that the pressure was dropping in the brain and keeping it at a level that would allow the brain to survive. For a full week more, she remained comatose. But then, slowly, she came back to life. Her pupils first came back and became reactive to light. And then she began to breathe on her own. And then one day, she simply awoke. At 2 weeks, she went home. Her right leg was paralyzed. Her right arm was paralyzed. She had slurred speech, but she got home. They still thought they had work to do, though. They continued to give her extensive and intensive physical therapy. And then 2 years later, here she is. Totally normal. Just like any other little girl that you know. This is what medicine is actually capable of today. But think about what that took. We've discovered how to save a child that had drowned under the water for 30 whole minutes and bring them back. But it's not like it is on ER. It's not a few chest compressions and she comes coughing and sputtering back to life. It was that whole entire process that had to be unfolded, involving hundreds of people, all kinds of machinery and equipment that needed to be made to go right, decisions one after the other that had to be orchestrated. Medicine is, I think, a test of our ability to handle extreme complexity. We are in an effort to manage a kind of complexity that man, I think, has never attempted it before. Certainly not in the range of what we are attempting to do. And I think understanding that what we are trying to manage is that degree of complexity across all the range of care that we provide is at the root of understanding not only our successes but also our failures, understanding why we have infection problems, why we have economic difficulties, why it's such a huge problem that we don't have insurance for so many people in our country. We've come to a moment, I think, of a very particular uncertainty, and that's whether we can actually handle this extreme complexity or not. One of my favorite essays in the world is an essay by two philosophers. They wrote it in the 70s. Their names were Samuel Gorovitz and Alistair McIntyre. And it was on the nature of human fallibility. What they pointed out was that at the root of our fallibility as human beings, we fail because of one of two reasons. Number one, they called ignorance, meaning that the knowledge simply isn't there to know how to get everything completely under our control. We don't have the knowledge to explain exactly how powerful and exactly when a cyclone is going to hit in Burma. And we don't have perfect certainty that an abdominal pain is actually just going to be fine after all. But on the other side, there is also what they called ignorance, meaning that the knowledge is there, but an individual failed to apply it correctly. What's interesting, I think, about our time is that both have become our problems. Our lives as human beings for nearly all of our existence has been governed primarily by ignorance. We didn't understand, for example, if you had a heart attack, we didn't understand how that heart attack might have been prevented even into the early 1950s. We didn't know, for example, that high blood pressure was a significant contributor to a likelihood of having coronary artery disease. And if we did know that that was a problem, we didn't have medications that we could really reliably use to control your blood pressure. Then when you had your heart attack, we didn't have ways to offer to really treat it. We would put you in bed, we'd give you some morphine, we'd tell you you couldn't get out of bed for the next 6 weeks, and then we'd say good luck. Fast forward to where we are today. We have easily a dozen things that we can do to help prevent you from having major coronary artery disease. We can control your blood pressure, we can control your cholesterol, we can encourage you to eat and not smoke, and eat properly and not smoke and exercise. We can do something about your homocysteine. We can look at your CRP levels. And then when you have a heart attack, we have lots of things that we know how to do now. We know that you need to get an EKG. We know it has to be interpreted properly. We know that a certain set of decisions need to be made about whether you're someone who needs to go directly to the cardiac cath lab. And if you are going to the cath lab, you should get your vessel opened up with that balloon within 90 minutes. Or maybe what you need to do is go directly to the operating room and have a cardiac bypass operation. Or actually, some people need a clot-busting drug, and that's what their treatment ought to be. And then there are still actually a few people who have a kind of heart attack that you don't have to do much at all. You just have to give them aspirin, a beta blocker, admit them to the floor, and watch them. So deciding which path you need to be on and then making that path actually work for a person has become part of our difficulty. We've discovered that there are still lots of things we don't know about treating people. We have terminal illnesses. We have ways we'd love to do more to prevent heart disease. But then we have also discovered that we know a lot now about how we can prevent disease, how we can treat and prevent disease, and that we're not doing it in any consistent way. I mentioned that door to balloon time. Your likelihood in America that if you had a heart attack and needed a catheterization and arrived in an emergency room with that diagnosis, the likelihood that you will get that balloon catheterization done within 90 minutes when it helps the best is still only about a 1/3 chance, as I understand it. So we have come to this question of whether we can we overcome what the philosophers have called our ineptitude, and what I would simply understand as the complexity of what we've discovered. We have now nearly 1 million physicians in the country. We have 2.5 million nurses. We have an equal number, if not larger, of additional personnel, physician's assistants, nurse practitioners, pharmacists, and so on, all trying to do this work to help people get the treatments that we know are available. And they're doing this, if you pick up one of the insurance procedure code books, you'll discover that what we're trying to do is enumerated in there. There are 3,700 different procedures that we are aiming to deliver on. We have 13,800 diagnosis codes representing different diagnoses that we have treatments for. In nearly all of these cases, there's something we can do to improve the quality of people's lives, to make their lives better with their disease, and in many instances, cure them. And yet, we can't make sure we're washing our hands right. 2 million people last year picked up an infection in the hospital, and 90,000 of them died from it. And that's why we've come to this question of whether we can actually handle making these things work well. Intensive care units, where she spent some time, are, I think, a very fascinating place because they represent the extent of the capability of what we can do. And an Israeli engineering study undertook to examine exactly how much work is involved in a typical ICU patient. And they found that the average patient has 178 different individual actions, steps in care that teams need to follow in order to keep that person alive over a 24-hour period. These are things like giving a drug, or changing a ventilator setting, or getting a chest x-ray. And then each of those have individual steps. Our solution for handling, making sure we deliver on those 178 actions, oh, I see, it's me. I'll turn off this thing. I thought I'd turned it off. Sorry about that. And now it'll make that noise while it shuts down. Our solution for managing all of those actions has been specialization. Our strategy over the last half century really has been to specialize. We've created cardiologists, and we've created dermatologists and urologists and so on. And then we've gone even further in the last decade or two to be super specialized. So now we have not just a cardiologist, but the interventional cardiologist, and the cardiologist who specializes in knowing how to do the echocardiograms, and the ones who work mainly in diagnostics and so on. In ICUs, our solution is the intensivist. It was a great source of angst that we were going to separate out ICU care, and the surgeon would not be in control of everything that happened in that intensive care unit to their patient admitted there. But the intensivists proved they could provide better results doing it. And yet at this point, we've even exceeded their ability as super specialists to handle what they're doing. That Israeli study I told you about was done in an ICU with intensivists, specialized people taking care 24 hours a day of the ICU patients. And they found that on the whole, it was a pretty remarkable success. They had a 99% success rate, but a 1% chance that they would make an error, a recognized error, in one of those steps of care. Doesn't sound like a big deal, 1%. But given that there were 178 things that had to go right in a given day, that meant that they found, on average, 2 different consequential errors for patients on an average day in an ICU. And so now what we're struggling with is, if what we're trying to make go right exceeds the capacity of the specialist to make it go right, what could we possibly offer to help matters? There are some other fields that have struggled with this question, and one is aviation. We often bring up the model of aviation as something to think about, and there are ways in which the model of aviation is not a good fit. They don't try to make 13,800 different kinds of airplanes get off the ground with the same group of people every day. But there are other ways in which it really is, they really have thought through things many years before we have about how they grapple with complexity. And one example is just with the question of how you get a plane up into the air. In the 1920s, for example, airplanes were not very complicated machines, as I understand it. I'm not a pilot. They were, getting a plane to take off was nerve-wracking, but it wasn't all that complex. You had an engine, you had to start it up, you had to get that thing going, fast enough to get moving and get it off the ground, and you hoped it got off the ground. But it was no more difficult than backing your car out of the garage. And you don't need anything in the way of a complicated protocol to understand how to get your car out of the garage consistently every morning. By 1935, though, things were beginning to change. The military came forward making a request to the manufacturers of aircraft for a design for a new long-range bomber. They wanted it to be able to cross the Atlantic. They wanted to be able to carry much bigger payloads, and various companies came up with different designs. But the design that stood head and shoulders above all of the others was this one. It was the Boeing Model 299. When they designed it, they put 2 engines on each wing instead of the usual 1 engine on each wing, and that gave it enormously more power. It could fly higher than any previous bomber had been able to fly. It could carry 5 times more payload. And when the gleaming silver thing flew over Seattle the first time, Seattle newspapermen dubbed it the Flying Fortress, and the name stuck ever since. But and so by the time they had designed several of these and put it through its paces, it was very clear that this was head and shoulders over what McDonnell and Douglas were able to offer for their designs, which were based on 1 engine on each wing. And so the military already made plans and put in place the order process for a couple hundred of these to be built. But they had one final step that was a necessary step for being fair to everybody, and that was that they needed to have an official flight competition. And so in October of 1935, all the different manufacturers came down with their test planes to demonstrate what they could do at Wright Air Force Field in Dayton, not terribly far from here. And so when this gleaming silver plane pulled out onto the runway, there was a large crowd that gathered around to see what was going to be the future of our military's air superiority. The plane got 300 feet off the ground, went into a very nice and steep ascent, and then suddenly dived and crashed to the ground. 3 crew died in the fire that followed that crash. And there was an investigation. What they found was that there was no mechanical failure. The plane had functioned just in the way that it should have, but there was what they called a human error. These turn out to be complex planes just by adding the 4 engines on. There are various things that the pilot is responsible for keeping track of in order to make sure that the plane gets off the ground in the proper way. Each of the engines has to be checked. There are also things I don't really understand, but these things called electric trim tabs on the wings, wing flaps whose positions need to be checked. Each engine had a certain pitch to the propellers that could be controlled, and so you had to decide what pitch you wanted to set the propellers at. There were the retractable landing gear, and so on, and so on, and so on. He had gotten through every step except he missed one. He had forgotten to take the lock off of something called the elevators. But that had been enough that although it could get off the ground, it couldn't be controlled in flight. And so it crashed. The military abandoned their plan for that contract. They ended up giving the contract to another of the manufacturers. And the reason they gave was that this had been proven to be simply too much airplane to fly reliably. Boeing was in danger of going under, and like it does today, they probably had a few friends up in Congress who could arrange for maybe an earmark or two. Because what happened was despite the negative reviews, the military agreed to buy at least a few copies of the plane. They had 5 or 6 that they agreed to purchase, which kept Boeing alive for long enough to try to salvage something. But they were then put in the position of having to make sure that this doesn't happen again. And so the pilots sat among themselves to try to figure out what to do. Their approach could have been the specialization approach. We just need to make even better trained people for flying these planes, give them more years. It's like surgery. Let's give them 8 years of training in order to learn how to fly these. But the reality was that the person who crashed that plane was the most senior and the most experienced person with flying these planes. And so they did not think that even if their most senior top pilot couldn't avoid a crash, the other pilots weren't very comfortable that they would be able to avoid the same situation. And so what they came up with was a checklist, a very simple thing. And I'd never seen what an airline checklist really looks about. You always hear about pilots' checklists. And I was able, it's the beautiful thing about Google. You can go on the web and you can pull these things up, and there it is. And this is the checklist for flying a Boeing 747. This is what's called the pocket checklist. They have a flip book checklist and a pocket checklist, but the pocket checklist is 2 pages long for flying a 747. It's not all that complicated, but you're having one person go through the checklist and the other person respond. Gear lever, up and off, autopilot, engaged, LNAV, whatever that is, on. Are the chocks removed, and so on. Well, it seemed like an utterly brainless thing, but they were trying to solve what they thought to be an utterly brainless problem, making sure you didn't miss a step when you have dozens or even hundreds of steps that you have to follow that you all know are the right steps to follow, and yet you know you're dropping them as well. And so implementing the checklist and doing what had never been done before, which was not inventing the checklist, but using it systematically across all of their airplane flights, meant that they ended up being able to fly those initial airplanes 1.8 million miles without a single mishap. As a result, the military changed its mind. They said this is a flyable plane. They ended up purchasing more than 13,000 of them, and this became the backbone for our bombing campaign across Europe during World War II that was a linchpin in our ability to win that war. Well, we in medicine have entered our B-17 phase. We are asking ourselves, is medicine simply too much for one doctor or nurse to fly? One of the people who recognized this is Peter Pronovost, whose work you all know very well because you all collaborated with him in his work where first he started at Johns Hopkins by saying, why do we continue to have infections in catheters, central lines put in the intensive care unit? 11% of their catheters, he found, in his own intensive care unit where he was director at Johns Hopkins, would become infected if they were in for 10 days or more. And the presumption was you needed to, that this is the cost of intensive care. There's, maybe you could lower it a little bit, but it's unavoidable. But he then had a simple thing that he asked the nurses to help him with, which was to see whether people were doing all the basic textbook stuff that was supposed to be happening. Because when you ask the doctor, say, yeah, of course we wash our hands before we put the lines in. Of course we sterilize the procedure site. We drape the whole patient. We put on a sterile gloves, and we put on a hat and a mask and a sterile gown, and then we put a sterile dressing on the site. But when you ask the nurses to check and just look and see what happens, found that 30% of the time the doctors skipped at least one of these steps. And so they implemented a checklist. This was the checklist they implemented, and they saw their infection rate go to 0 in their ICU. We've discovered various things like that along the way, things that seem to be very successful in a local environment. But the real step that he took that made it remarkable was then he was approached by the Michigan Hospital Association, and he agreed to work together to see if it could be implemented across an entire state. And so the hospitals of this state worked together in collaboration. That itself extremely unusual. And then they agreed to follow a basic set of steps. they understood that you could throw a checklist out into the hospitals, and the reason why it wouldn't work is because it's hard to make something as simple as this work. It's hard to get people to go along with it, and so he asked for an infrastructure to go along with it, that there be one point person in every hospital that have the responsibility for this, and that second, that they have a conference call every 2 weeks where they would simply share information on how it's going. And along the way, they would try putting the checklist in, and they'd share notes. So the nurses hate doing it at our hospital, or the physicians think this is stupid. Well, how did you deal with that? What did you learn? They dealt with those kinds of problems, but then they also discovered certain things which you just never could have figured out by, no matter how conscientious you are as a physician trying to follow steps along. For example, he assigned them 1 week to simply walk down to their ICUs and ask, how many ICUs are missing the chlorhexidine soap that you need to properly sterilize the site? And what he heard back 2 weeks later was 2/3 of the ICUs were out of stock with the soap. And so they could implement a process then working at that level where they could make sure, alert the people who actually knew about it, because as an individual physician, what do you do if they're out of soap? You call someone up, you yell at them, you say, oh, what the heck can I do? And you just go on about your way. But he was able to orchestrate a process where the soap could be in those ICUs within 4 weeks after that. And so on, until it took them 3 months, and they actually got the checklists up and going in all 67 hospitals that have ICUs in Michigan. And then 12 months after that, they saw what the results were of their infection rates. Another thing they did, which was they were actually following whether this thing was working. And they saw that the infection rates had dropped 2/3 in the entire state. The worst hospital in Michigan has a better infection rate than 90% of American hospitals now. That is stunning. 1,500 lives were saved in that first year. $200 million. We don't normally have that ability to understand, to overcome failure. But we have recognized now a few clues about how we overcome the complexity of what we're doing. We have now started to ask, well, we have 80,000 catheter infections in the country. Can we make what's happened in Michigan happen all across the country? It's a hard question. It's very unclear. It's very clear that Spain and the Netherlands will probably beat us to it. They're on their way to being able to implement across their countries. But that's our first task, is to make that happen. And then the second is, can we take on a larger problem? We do 40 million operations across the country every year, 1 for every 8 Americans in the country. And in a study that we did in 1999 in the states of Utah and Colorado in 28 different hospitals, we found that the complication rates are around 3%. That is, 3% of those operations will result in death, disability, or a prolonged hospital stay because of the treatment rather than because of the disease they are treating. And now we can ask, can we actually improve this? Can we make a difference? We did a further study, which is going to be coming out in the next couple of months, so this is still not data for publication yet. But we found that from modeling, looking at operations where they have been tracked around the world, that there were approximately 230 million operations done in 2004. It is a sign of just how much the complexity of surgery has become something that we engage in across the entire world. There is not a country where they don't have a major surgical system to provide care. And the troubles are not insignificant. If there is a 3% complication rate, then we're talking about 7 million who are left either with death or disability every year in the world. And then 1 million of those are deaths at a minimum. And so the WHO asked us whether I would be willing to head up an effort to reduce complications and deaths in surgery globally. because this is now twice as many operations being done in the world as there are child deliveries. And this is with at least 100-fold increase in the risk compared to childbirth. And so to them, this has become a public health issue, doing something about this. So I, of course, said no. This is crazy. How can you do anything about this? I don't know how to fix our complication rate at my hospital at the Brigham, let alone what we're going to do around the world. But they conned me into at least having a meeting. And so we had a meeting in January of 2007 where we brought anesthesiologists and surgeons and infectious disease experts from all around the world who could tell us about the experiences of trying to control complications and reduce deaths, and also what the knowledge is that we have to the extent we have it. And they pointed to the possibility of being able to have a series of things that we could do to improve care in surgery. And so we embarked on a 2-year effort, and we're now about halfway through. One of the first things that we did then was to try to examine what the actual conditions are in various places around the world, and we have 8 collaborating sites that range from the rich, with Seattle and Toronto and London, to the middle-income settings like Amman, Jordan, and Manila in the Philippines, to the very poor in New Delhi and a rural district in Tanzania. And then we have been gathering information from the care of surgical patients in all of these places. This is our preliminary analysis of 2,600. We have 6,000 enrolled now. What we found was that the complication rates are not insignificant. It's certainly not 3%. These are just inpatient complications, and the complication rates range from 3% to 22%, depending on where you are, and the death rates are in the range of 1% to 2% overall worldwide. We use a surgical APGAR score rating how well care goes based on the amount of blood loss and the lowest heart rate, lowest blood pressure patients, which correlates very well with complications and deaths. And we were able to understand that you could even give individual information to surgeons about how their operations have gone based on those 3 parameters. But the important thing was that we also, I should go back and say that infections turned out to be about half of these complications. And we know for sure there are things that we can do to improve infections. We also saw that a number 2 on there was complications from bleeding and a failure to resuscitate people adequately. And then number 3 was problems with anesthesia death or anesthesia complications. The further thing was we looked at actually how the process of care went in the individual places, and there was almost no matter where you were, there was clear opportunities for improvement. Nearly everywhere was using a pulse oximeter, though not everybody, and not consistently. Everyone we were working with had access to pulse oximetry, and even then we're not in a couple of places using it quite in everybody. We also saw that antibiotics, which are known to be important to give in the 60 minutes before an incision, not too long earlier than that, and certainly not after the incision, because you lose the effect if you have not got the antibiotics already in. And nearly all the sites were terribly inconsistent about being able to make that work. We also saw many of the deaths, as I mentioned, were related to bleeding, and a failure to have 2 IVs seems certainly that you want to have as a standard that if you're going to lose more than half a liter of blood, that you have 2 IVs in place so you can resuscitate someone adequately. And most of the places did not have a consistent practice of making sure 2 IVs were in during emergency C-sections, for example. And we saw that those patients, as a result, had instability and a potential for increase in complications. So we put that together and recognized that then we could do what Peter had done with you here, which was we could make a checklist. And we could target it on the major mishaps that we know can occur. In particular, we could make sure before the induction of anesthesia that the team confirms out loud that this patient either has a difficult airway, does not have a difficult airway, or if they do have a difficulty with being able to safely put them to sleep, that we have the needed equipment and assistance available for them. Or that if this was someone who could lose more than a half liter of blood, that we had at least 2 IVs in place or a central line and adequate fluid and blood available. At the time of a timeout where we, in the United States, already check to make sure that you have the right person and the right side of their body we're operating on, we appended a more developed set of things that they could check, which includes making sure the antibiotic has been given before the knife goes to skin, that the surgeon has been able to explain to the team whether there's any critical or unexpected steps out of the routine that they should know about, how long the operation is going to take, what the anticipated blood loss will be. We then have a last step at the end of the operation where, before the surgeon leaves the operating room, they would check to see that specimens are labeled correctly, counts are completed, and also, probably the most important, that they've discussed how the operation went and what the key concerns for the recovery of the patient is, because all of the care is about to be handed over to a recovery room where things may or may not be properly passed along. I mentioned we're at about 6,000 patients. We have 4,000 patients who we just tracked how the care was going. And then we're about 2,000 patients in with being able to see whether this changes the care. We have already seen significant change, sort of qualitatively improved differences in whether the process of care has improved, whether an antibiotic gets in on time, and so on. But we won't know until the final 8,000 whether we see actual reductions in deaths and complications. But in June, we'll be announcing this checklist publicly. It has already, in Amman, Jordan, for example, been so effective for them that they have adopted it nationwide in Jordan, with a plan to have it in every operating room in Jordan by the end of 2009. And the chief surgeon for the National Health Service has, in the UK, has also now put in place a plan to implement a checklist like this for by the end of 2009. The aim of this is not that this is necessarily going to be the solution. The aim is to understand the process that has got us there. It's first by trying to ask what we could do to take 40 million operations and make sure that we're actually doing them better now than we did last year and better next year than we've done them this year. And the only way we know that is by having some basic vital statistics, knowing how many deaths there are, using a measure, something like a surgical APGAR score or some other measure that tells you very simply how many cases have a lot of blood loss and how many don't, and can we change that. And then you paired it with an innovation, trying a checklist and seeing, does it make a difference? And if it doesn't, what else could we try to do? Or if it does, maybe there are other things that we can do. We are, in our next project, for example, working with manufacturers to try to create a low-cost pulse oximeter so that parts of the world that do not have access to pulse oximeters can actually have them so they can measure how well patients are breathing and not have the anesthesia disasters we see. We also learned lots of lessons about just how hard it is to implement these kinds of things. When we tried in a couple of locations to just simply hand out the checklists across all of their operating rooms, people revolted. They didn't understand what this was about. They thought someone was trying to police them. This was being imposed from the outside. So we learned the way you have to do this, put it in one operating room, the chief of surgery, chief of anesthesia, use it themselves, and then work out the kinks, because every local environment is different and it's not going to flow in the same way. And it would almost always take us 2 or 3 days to get it to work with a motivated team in one operating room. But once we worked it out, had the nuances for the place, then we could go to 3 operating rooms, and then we could go throughout a whole facility. There is nothing easy about something simple. There is a science to making systems work, and that's part of what we discovered. But that's also just understanding that for all the knowledge we've discovered, and we have an incredible discovery machine in America, we have not yet turned that knowledge into behavior. And that's the trick of trying to do what we do. The checklist, I think, will be only one tool that we use along the way. The goal, though, is a different goal than many academic centers like your own may have for how we make a difference. We are used to making ourselves the best, but that's a different priority from what I'm talking about here. And it's the kind of priority that this man, I think, had in mind a century ago, one of my heroes, William Halsted, a hero despite the fact that he had a cocaine addiction. He was chief of surgery at Johns Hopkins, and he understood that his job was not to make Johns Hopkins the high-volume player in the Baltimore-Washington market at the turn of the last century. He understood that his job was to learn how to make surgical care so straightforward that it could be done by surgeons anywhere across the country of much more variable ability and opportunity and resources and training. And so he did various things that I think were revolutionary. For example, he was the one who introduced gloves into the operating room. Until then, surgeons learned from Lister you had to wash your hands in carbolic acid in order to make sure that things were antiseptic. But the carbolic acid burned, and many surgeons were not necessarily consistent about using the hand wash. One of his nurses ended up wearing gloves because her hands would burn, and he realized that she was onto something because this was a consistent way you could make sure that things were antiseptic. And so the gloves were introduced. He was the one who introduced the concept of residency training. Whereas before medicine was an apprenticeship with one person and you just learned what they did, he introduced the idea that it's a graduated set of responsibilities that you gain over time from a system of people rotating around. And we have been building our quality of our training on that system ever since. He was the one who, of course, invented numerous operations, but his target every time, for example, he invented the most common operation done in America, which was the Halsted hernia repair. It was a repair for a problem that was a plague for young men in particular. They couldn't work with the large hernias that began to develop. It was, for the most part, unfixable under any of the complicated techniques that people had devised. People couldn't learn them well enough to consistently do them across the country. So he simplified the operation. He made it much more straightforward. A lot of people learned how to do it very quickly. And they could do it with a 95% success, a low complication rate, and that was why it became a problem that became fixable in the country by lots and lots of different people. In other words, he understood that our mission as scientists, as academicians, is to be able to make low-volume care achieve high-volume results anywhere in the country or even around the world. We need to do that not just in surgery. We have, for example, 17 million people who get a depression every year. And we know lots of things about how those patients ought to be treated. There's some medical illnesses that can cause it, and they should have their thyroid hormone levels checked, for example. And if they're elderly, you should look for whether they have signs of Parkinson's. But how consistently do people who walk in the door get any of that as part of what happens to them when they come in with a depression? There are certain things that can be done before you start putting them on drugs, but what we do is that people come in, they complain. We're not systematic about how we diagnose what they have, and then we give them Prozac and have them go out the door. But a simple checklist or another approach could change the way people in the country are cared for with depression. And we actually might be able to make it so that in 2009, they're more likely to have their depression lifted than ever before. And so on and so on. Eventually, across all 13,800 different diagnoses that we take care of. I ended up having a chance to talk to the lead author of that report on that 3-year-old girl who was saved from drowning. The lead author is a cardiac surgeon in a little town in Austria called Klagenfurt, and his name is Markus Thalmann. And I thought it was very impressive to me, not just because they had saved that girl, but because they had done it in a place that was not a massive academic medical center like the place that I practice in or that you practice in. The town of Klagenfurt is a small town in the Austrian Alps. And when I asked him how they ever ended up trying to save this girl, he said that they had actually for many years recognized a recurrent problem like the one she had. They're high enough up in the Alps that they have every year avalanches that bury people, and they will come in arrest and hypothermic, having suffocated. And in the frozen lakes all around the town, there are recurrent drownings as well. And as a surgeon there, he would see these patients come in, and he would be convinced that some of them were savable. And that they already knew that if you could get them onto bypass and then maybe onto ECMO and into intensive care and so on, that you could potentially do this. And so their solution for this was that the child would come in or the patient would come in, and then they would say, just do it. Let's just do it. Everybody do their job. But how often does yelling at people actually make any of this occur? It didn't. They had no survivors. And so he decided to look at the pattern of what was happening. And the pattern he saw, the most important pattern he thought he saw in the numbers, was a lack of speed. That they needed to try to orchestrate an array of people to be at the ready and equipment to be at the ready. They needed a helicopter at the rescue. They needed a trauma surgeon to receive them. They needed an expert cardiac anesthesiologist, not on the phone 40 minutes away, but in-house, there, ready to go. They needed a perfusion team to get the pump up and going. They needed the pump working. They needed the ICU ready to receive them. And looking back, every time one thing or another would drop through. And so he made a checklist. And interestingly, he gave the checklist to the people with probably the least power along the way in influencing what the care was going to be, but the ones who probably needed the most influence. He gave it to the rescue team, and their part of the checklist was that if they recognized this situation, they made sure to call up the person who had the checklist actually in their hands, and that was the telephone operator at the hospital. And the telephone operator had a list of people that he or she would need to go down as soon as this alert was activated. It didn't go to a doctor to say it was okay. It didn't go to a nurse to say it was okay. It went from the rescue team to a telephone operator who then went through the list and got everybody else in place. The girl was the first survivor from that checklist, and they've had several others since then. He told me about the most recent one. A mother and daughter had been in a car on a road, and they crashed through a guardrail that went over a cliff, and it went into a mountain river. The mother died on impact, but the daughter didn't. She was alive. And then she went down with the car under the water. The rescuers saw her actually go down under the water, but could not get to her quickly enough. They got her finally out, though. She was again frozen and pulseless and not breathing. But the system went like clockwork. The hospital was notified. She arrived within minutes. They crashed her onto cardiac bypass. Her heart warmed up and then began to come back. They then got her breathing. They put her on a ventilator. They got her IV fluids and the right drugs to keep her going. And by the next day in the ICU, all her tubes and lines were removed. And then the next day after that, she was sitting up in bed, ready to go home. Thank you for the chance to come talk to you. And I think this is a great place where we've learned a lot about breakthroughs like this as well. So thank you.
I want to thank you, Atul, for a wonderful talk. I think you all have the same impression that I do, that he has a remarkable ability to take a complex subject and make it so interesting and understandable. It's a very rare quality. Thank you for giving us that talk, Atul. I think we might have time for one or two questions. Before we do that, though, I want to make sure I recognize Marianne Udow Phillips, who's here from the Center for Research in Healthcare Quality and Transformation, who also helped us to bring Atul here to talk to us today. But are there one or two questions from the audience? Sir.
Thank you. In the beginning of your talk, you mentioned the two things that the philosophers in the essay had said. One was ignorance.
And the other they called ineptitude. Knowledge is there, but an individual fails to apply it correctly.
One of the sources of error which you really didn't address today, but which you have addressed earlier, is inexperience. One of your earliest essays addresses that question with great penetration. To learn to do surgery requires inexperienced people taking unavoidable risks. I suppose there's no escape from that quandary, but my question is this. That was probably 10 or 12 years ago when you wrote that. In those years, you've done a lot of different sorts of things. Have you any further observations about that quandary and that kind of error?
Yeah, I think it's a deeply ethical quandary because I remain convinced that we cannot teach people without their making mistakes, and that they will have to learn from those mistakes. And the classic thing that I have in mind is, I still will have a medical student who comes to see me, and I'll have a patient on the floor who needs an NG tube put in, a nasogastric tube to go down into their stomach. And there's the question of, I've walked them through all the steps about how you put that nasogastric tube in. We can even get a dummy and have them learn how to thread it in the nose and so on. But at a certain point, they have to take that tube, 3 feet long, and stick it in somebody's nose as they cough and gag, trying to get it down, and it's going to be uncomfortable. And there is, I suppose, some distance we can come, which we have not come, with making better simulators and so on. But given the 3,700 different kinds of procedures we do in medicine, and there are many ramifications more from that, we are still for a long time going to be in an era where people have to learn on human beings and practice upon them. And there will always be that uncomfortable moment for me as a teacher where I will turn to them and say, and I turn to my own patient and say, meet Harriet so-and-so, the medical student. She's going to help me put in this NG tube, is the way I'll say it. But it's them needing to know how to put that in and learn to do it. We have a responsibility to minimize the risk. We have a responsibility to minimize the pain. We also have a responsibility to the future that we have people who learn how to do these things. And I think we will be continuing to grapple with this quandary. Supervision is important, and I find from some of the patterns we've seen in research about care that we still are surprisingly, we've gotten a lot better at supervision, but there are still areas we fall through on that. So I don't think the fact that we have to learn from our mistakes absolves us from responsibility to try to learn how to let them learn before doing and not just by doing. But we will all, and I continue to need, I myself am, I don't feel particularly, I'm 5 years into my practice as a surgeon, and I know that people senior to me are doing better than I am at certain things, and I still have my learning curve to climb.
Regulatory agencies have tried to prevent using the checklist because they felt it was an experimental project. There seems to be somewhat of a disconnect between people trying to do these things and others saying you can't, or you need to go through another checklist. How do you feel about that?
I understand. I forgot it, that if we have web viewers, and so I'll repeat the question that you asked, and I think it's an important one because what you pointed out is that regulatory agencies suspended the checklist program in Michigan for being a violation of ethics. And their criticism was that they had called themselves a quality improvement program, but had not gone through IRB review in every hospital that they were in, and had not grappled with a question of whether the patients ought to give consent before being asked to change care to include a checklist. I thought it was absolutely crazy, and suspending a place like Johns Hopkins, which had had a prior episode and therefore is very sensitive to the adverse publicity of, for good reason, the place that violates ethics ought to be regarded with some contempt in the country. But I wrote an article in defense of Johns Hopkins and Peter Pronovost in the New York Times precisely because this was, I thought, ethics regulations getting in the way of ethical care. The trouble is, and it's not their fault, we base our ethics regulations around a set of ideas that if you are doing research on people, we should protect you from having to participate in that because it's not necessarily for your benefit. The trouble is that now the definitions of research have become very murky because we have data everywhere. Researching was an elite profession. It was something that a narrow few gathered information and looked at whether a drug worked or whether various things happened. Now we have electronic records and data everywhere, and you have an opportunity to test and ask questions about how your own system is working. But if you share information outside of your institution among multiple institutions, and are learning from the data that you're getting from those institutions, that by definition is research, and therefore subject to federal review and oversight. And we have not settled that quandary because it means that every cancer registry, every trauma registry, my checklist program, and other things are in potential violation of research ethics rules. Half of the hospitals in Michigan don't have an IRB, but they all participate in trauma registries and transplant registries and so on. And we use those registries to find patterns in where failures in care are occurring and then give advice to people about what they can do to improve matters. And this is how we want things to be. We want every clinician, nurse, doctor to become researchers themselves, to notice how well they're doing, share the results with lots of their colleagues, and then discover what is working and what isn't. But the ethics regulations right now make that extremely tough. And the ruling in particular, although they lifted the ban on Hopkins, they did not clarify whether the rules are the way they are. And that was, I think, on purpose because now they're in a process of trying to understand how you can draw lines that make it clear we don't want another Tuskegee. We do not want people getting drugs or kinds of care that are experiments upon them. At the same time, what we're doing currently in medical care has major lack of safety. A failure to look at what's going on is the most unsafe thing and the riskiest thing we can do for people. And so we need to remove barriers that are preventing people from sharing information and learning about what they could be doing better.
Okay, time for one more question, sir.
Just your thoughts on the checklist. Do you think a checklist would prevent people from thinking outside the box as rare as the situations might be when they need to think outside the box?
So there's the question is whether a checklist could prevent people from thinking outside the box, turn them into a kind of rote mentality rather than thinking people, which is what we want in the profession. There is a huge difference between a kind of cookbook approach and a checklist approach, and it's understanding this. When we make protocols and guidelines, it is an effort to try to regiment every step that happens along the way. But when you make a checklist, it's with a different philosophy in mind. You're looking for the 5 or 7 things or 10 things, actually the smaller number the better, 5 or 7 things that everybody agrees should happen but doesn't happen. And you want to pick the highest value things that checklist is checking on, the things that can make the biggest difference. But you are only doing the things that people already agree need to be the ones that are done. And then you're checking along the way that you've made that happen. And so when you're flying a 747, It's not an instruction manual saying, okay, now turn the wheel to the left. If the wind is coming in this way, then go a little bit to the right that way. No, it says, there's a fascinating flip side to the 747 one, which is emergency procedures. And they will say, you know, if you run out of fuel, if the fuel gauge says empty, here are the 5 things you got to check real quick. And don't forget these. All of these are your troubleshooting way. But it doesn't say, and now here's how you fly the plane and how you do what you do. It just says at the very end, if you come to the bottom and you still can't figure out the way to do it, you know, start thinking about how you're going to be able to land a plane. This is where we are in American medicine. I'd say it's purely guessing, but it's at least 2/3 of what we do is not regimented, can't be put down in a simple just do the following things. But there is about 1/3 that are very basic. I was just looking at some data for thyroid cancer patients who die from thyroid cancers. And there have only been a couple of reports on why people die from thyroid cancer. We thought we have basically a cure for thyroid cancer nowadays. And it turned out that at least half of the deaths were people who only got half of their thyroid removed. If we know anything about thyroid cancer nowadays, we know you have to remove the whole thyroid. And so we could all make a checklist that just had a single box. Thyroid cancer, is the thyroid out? And it could have prevented half of those deaths. That doesn't mean that our brains get to turn off, though. And I think being able to design our systems, it's very essential that we continue to make it actually easier for people to think and use their brains in the situations where that's what they need to be doing, and not spend their time worrying about, all right, did everybody wash their hands? The idea of a checklist could hopefully take that off of their menu about that part having to be what they worry about and put their energies on what they are really capable of, solving problems on the fly.